Imagine treating a patient with life-saving medications only to discover that the very drugs used during resuscitation may have triggered a temporary heart failure syndrome. Today I am presenting a fascinating and important ICU case of stress-induced cardiomyopathy, also known as Takotsubo Cardiomyopathy, triggered in the setting of severe asthma exacerbation, epinephrine exposure, and catecholamine surge. Hello everyone, in this video I will walk through a unique clinical case involving a 46-year-old female who developed Takotsubo cardiomyopathy or TCM after receiving AP and intensive bronchodilator therapy during acute respiratory failure. This case highlights the delicate balance between emergency treatment and unintended cardiovascular consequences. So, let's get into the case. A 46-year-old woman was brought to the emergency department with the worsening shortness of breath for one day along with chest pain. During transport by EMS, she received AP and duodenal nebulizations because of severe respiratory distress from asthma exacerbation. On arrival to the hospital, she was confused, agitated, and critically hypoxic. Her oxygen saturation was only around 70% in room air. Because of acute respiratory failure, she was emergently intubated. Initial lab studies showed leukocytosis and significantly elevated troponin levels, which rose from 140 to 1263. At this point, concern for ACS was very high. An echocardiogram revealed severe reduced left ventricular systolic function. To further evaluate for coronary artery disease, the patient underwent left heart catheterization. Interestingly, the coronaries were essentially normal. However, imaging demonstrated classic findings of Takotsubo cardiomyopathy: apical echinacea, basal hyperkinesia, and ballooning of the left ventricle. These findings confirm the diagnosis. So, what exactly is Takotsubo cardiomyopathy? It is a transient and reversible form of systolic heart failure that mimics acute MI but without obstructive coronary artery disease. Patient commonly presents with chest pain, dyspnea, elevated cardiac enzyme, and EKG changes that can look exactly like a heart attack. The pathophysiology is not completely understood, but the leading theory involves a sudden surge of catecholamines. This catecholamines excess causes myocardial stunning and abnormal ventricular wall motion. In this patient, several triggers likely contributed. Number one, severe physiologic stress from asthma exacerbation, endogenous adrenergic stimulation, and exogenous catecholamines such as AP and albuterol. So this is particularly important in ICU and emergency settings because epinephrine is commonly used in critically ill patients. Although life-saving high catecholamine exposure may occasionally precipitate Takotsubo cardiomyopathy. Early recognition is important because management differs from traditional ischemic heart disease, and fortunately cardiac function in TCM is often reversible with supportive care. Thank you so much for watching this case presentation. If you found this discussion helpful, don't forget to like, subscribe, and share for more clinical case reviews and medical education content. And remember, sometimes the body's stress response itself can temporarily break the heart. Thank you.